Okay, I'm Dr. Luanne Billingsley, and I'm an associate professor at Southeastern Louisiana, and I also serve as the director for the Center for Digital Health and the College of Nursing. And my areas of interest have included interprofessional collaboration that uses technology to enhance deliver and sustain evidence-based care. We're located on a 500-acre campus in Louisiana, USA, and this is right outside of New Orleans. We have about 15,000 students enrolled in graduate and undergraduate programs. I do not have any disclosures to declare. Healthcare organizations are facing unprecedented challenges as they have to respond to accommodate the surge of COVID-19 positive patients while keeping frontline staff and patients safe. The healthcare industry has seen rapid adoption of video conferencing and collaboration tools to provide care to patients, regardless of where the patients or clinicians are located, while also trying to mitigate risk of exposure to coronavirus. Due to the isolation and social distancing to maintain patient and staff safety during COVID-19 pandemic, nurses have facilitated these critical patient-family communications. Video conferencing applications have aided the socially distanced families to connect with dying loved ones. This presentation will explore the expanded use of video conferencing, apply the lived experience of using these technologies at the end of life, and evaluate some tools to support nurses' well-being. My first experience with looking at using technology to share the death experience came back in 2013. Poignant tweets by a well-known American journalist led to a national conversation in the USA about publicly sharing the death experience. Simon Scott tweeted his interactions and reflections on his mother's illness and her subsequent death to his more than 1.2 million Twitter followers. This conversation highlighted challenges encountered through the use of social media at the end of life. And at that time, there was a lack of information about the uses and benefits of using social media for health communication among the general public, patients, and health professionals, particularly on the subject of death and dying. During the COVID-19 pandemic, doctors, nurses, and social workers connected families and patients by phone or video conference, even when critically ill patients on ventilators could no longer speak. Providers understood the fear and grief these families experienced when they couldn't be at bedside. Video conferencing use accelerated during the COVID-19 pandemic. And I think this is true throughout the world. Okay. Communicating through social media has allowed users to share content, their opinions, and insights and experiences. Healthcare providers even began back in 2013 to use social media platforms to share relevant health information with patients. And this resulted in better informed patients. However, it brought about another problem, which we're still addressing today, and that's addressing digital health literacy. Most deaths often occur in hospitals, nursing homes, and hospices, making your patients often feel socially isolated. Social media has provided an opportunity for patients, families, and friends and other caregivers to connect regardless of the time and distance. And an astounding percentage of people using social media due to the increase in improved, with smartphones, and then the improved connectivity has helped. And many are older persons who use the applications to obtain tailored health information and share health experiences. Social media platforms also provided for support for bereaved relatives. Video conferencing has accelerated in the pandemic. And there's so many competing priorities in the hospitals now to obtain PPE, to develop infection protocols and prepare for surges. The emotional well-being of patients has lagged far behind the physical well-being. Technology was an excellent choice to connect patients. In the beginning, indeed, just listening to the voices of family members were better than nothing. But voices could barely be heard over swirling high flow oxygen, IV pumps, and the constant alarms. An alternate approach was needed to overcome these communication barriers. Video conferencing via iPads was adopted to allow the patients to connect face-to-face with their loved ones and critically ill and intubated, a way for their families to see their condition. This solution has now been used in several hospital settings. In 2020, video conferencing isn't new. Providers and patients have used video conferencing and telehealth for years. Although prior to COVID-19, there was a slow adoption in the United States, the application has also been used for several years to share virtual funerals with geographically distanced loved ones. Perhaps the saddest aspect of the pandemic is the lonely death of a loved one. Early on, frontline nurses and others often facilitated the critical patient family communications using video conferencing. Later, compassionate rounding programs in some of the hospital systems were initiated, sometimes with redeployed staff, so that they could provide emotional support and a human connection with friends and family that cannot be at bedside. And there's so many instances of this every night on the news. Video conferencing could be particularly relevant in improving communication. The technology allowed providers to discuss treatment and medical issues also. It could either be live or they recorded videos to share with patients and family members. And providers helped COVID-19 patients say final goodbyes to their family who could not be present. And mostly this was done using FaceTime apps or FaceTime app on iPads. Although they're unable to be at bedside, video conferencing offers that sense of being present. Here are some popular video conferencing tools that have been used this past year. They facilitate the communication of 2 or more users, a combination of high quality audio and video over internet protocol networks. And the use of video conferencing has been, I think, expanded because they simulate real and face-to-face communication. Now, some of these apps are more secure than others. And in early 2020, Zoom, a popular video conferencing app, suffered from the issue called Zoom bombing that occurred when an uninvited person joins the meeting and becomes disruptive. Since then, the company has made some security features a default, and then also additional settings were made available. And then a big takeaway from that was that users were advised not to share their meeting links publicly. And of course, you have to consider HIPAA compliance, and some of these apps are better than others with HIPAA and end-to-end encryption. And sometimes you have to pay for it, but some of the free choices here are very good to offer for your patients and families. Of course, there are privacy and security considerations using any technology, and potential issues with using video conferencing include the quality concerns and lack of reliability, confidentiality, and privacy. But over time, it's been proven that consumers appear to accept these privacy limitations to obtain the benefits of remote communications. Always consider your cybersecurity issues. And crisis groups have collected iPads and done some fundraising to be able to provide the devices to patients so that they could participate in video chats. Also, another takeaway there is that nurses should always be familiar with their workplace policies and vigilant to protect their patients' privacy from media misuse by families, friends, and others. So we, as nurses, we still do have a responsibility to the patient to make sure that, they're not being abused with the social media. My husband of 33 years, and it's ironic because he edited a couple of manuscripts from 2013 and 2020, where I had written on sharing the death experience using technology. And the reason I got really interested in that, after hearing about it, I walked into my clinical setting and asked my students, last semester nursing students, I asked them, would they feel comfortable facilitating, communication with social media? And out of 8 students, they were very split on the idea. And so that piqued my interest. And through the years, I had asked, at some point during the clinical experience, if they felt comfortable doing that. And a lot of them were, would fall back on policy and stuff. But now in the COVID setting, 100% would use technology to help patients communicate. So anyway, getting on to the lived experience, my husband was very much aware of my interest in this and how it had transitioned. He passed away in December of 2020 as a result of COVID pneumonia. With the somewhat relaxed hospital inpatient visitation restrictions and being post-COVID myself, I was able to stay at his bedside for 8 days and nights. It was ironic because it was just as the journalist had explained at that back in 2013. I was not aware that the early communications would be the beginning of sharing my husband's death experience. As a family member, I had an immense hope, but slowly over the 8 days, it was hard not to think like a nurse and begin connecting the dots. Patho and physiology were not something I wanted to really think about. But at about day 4 or 5, my professional training took over and I began to function as both a wife and a nurse. I think this helped as the plan of care had shifted to comfort measures. I did feel a tremendous responsibility to keep our family and close friends who could not be with us informed. Without technology, it would have been that isolating and lonely death, and this was a man who lived a full life. It is important to remember that sharing the death experience also has a benefit to family and friends. I was definitely the one that facilitated the communications as he became weaker. As we moved through the week, communications became shorter and then they became less frequent. By this time, family knew that the end was near and they turned to each other to begin the grieving process. Maybe I felt this responsibility to share the information because my husband had been hospitalized 2 previous times leading up to his third and final admission. I was not allowed to visit due to the isolation restrictions at the time. And I was also still positive for COVID. It was hard not being able to visit, but at the time he could still make some phone calls. And by the time he was admitted for the third and final time, I was allowed to stay at bedside, which I did for the entire week. We both knew how fortunate we were to be together because we had watched the stories worldwide of loved ones being separated during this time. I did find that communication was done within groups instead of one large group. In the beginning, we used video calls for family calls and later individual FaceTime. The 3 siblings were on 4 corners of the United States and in various stages and phases of lockdown. So they were familiar with video conferencing because we'd started using this as a way to communicate during the pandemic. So they were easily moved to the Zoom, using the Zoom platform to communicate. His daughters preferred to use the FaceTime app. They'd often call, and if it was appropriate and he was strong enough, then I'd allow them to switch to the FaceTime app. His stepchildren and grandchildren preferred group text, and then they would communicate and talk about the information that was shared. Those could be checked throughout the day as well. And then if you ever think about what needs to be shared, I didn't know at the time, but in the end, family and friends wanted to know he was comfortable, that he fought hard, and he received the best care available. By the time the end came, it was a peaceful and good death. Loved ones were okay at the end of life and shared that they felt informed and present. Some of the lessons learned: communicate how and when social media, when your information could be shared on social media. I started with the one that was the best communicator on social media and sort of talked about things that, might need to be curbed. And remind persons not to record while video conferencing or forward information without permission. Set up groups for video conferencing, such as Google and Zoom. And then you can have one-on-one or smaller groups with the FaceTime apps. Always consider the loved one and maintain their dignity. Sharing video conferencing, social media, and other apps, it's not for everyone. So it's something to be assessed. And but I wouldn't expect that everyone would be comfortable with this. Some implications for nursing. The pandemics required unprecedented responses from everyone. And there's no doubt that we're going to have compassion fatigue, burnout, after over a year of stepping up day after day for long hours to meet the needs of the sick and dying. Helping patients and their families deal with death and grief, while it's a fundamental part of nursing, and nurses, they develop attachments to their dying patients. But this repeated exposure to death and grief is a stress factor that can ultimately lead to nurse burnout. And burnout's been associated with negative patient outcomes, and emotional detachment from caring for the dying could impact quality of care, both for the dying patient and their family. So taking care of yourself is essential. And one place to go for tools and apps to support the mental health and resilience of all nurses is the American Nurses Association COVID-19 Resource Center. I point this out because many times nurses are alone when they reflect. So there are many tools there. One of them is the Narrative Expressive Writing app, and it helps you process your thoughts. Very simple, because the last thing you want to do is to have to feel like you're writing a dissertation when you're trying to decompress. There are podcasts and apps to improve overall self-care. And if you're not sure where to begin, then take the stress self-assessment. I encourage you to, use these tools or some that have been shared on your websites. Here's just one example of something that you could do. Experts expect that 1 in 3 nurses could suffer from PTSD post-pandemic. And here's a share graphic tool from the Well-Being Initiative website, and it shares some steps to decompress. One is to review, acknowledge a challenge you've faced, and take a deep breath and let it go. Reflect. However small, consider and appreciate 3 positives in your day. Regroup, offer support to your colleagues, and ask for help when you need it. Re-energize. Turn your attention to home and then focus on relaxing and resting. During the pandemic, nurses have offered comfort to dying patients that's usually provided by the family. And because of this, we need further research to determine if sharing the patient death experience through video conferencing, whether this has a positive influence on nurses' attitudes toward the care of dying patients, because we know their relationship can affect the outcomes of our dying patients and their families. Patients and their families are comfortable using video conferencing apps to communicate. And so if telehealth and video conferencing are a part of the new healthcare normal, then support of connectivity and devices such as iPads are going to be necessary. Also, you may want to consider interprofessional education and training, because this could improve the overall engagement of the quality of video conferencing experiences. As applications continue to develop, the identification and management of ethical and legal issues will be critical to the success in improving communication. To give back to nursing and to thank the nurses who supported us at my husband's end of life, my well-being initiatives have included funding a nursing scholarship in remembrance of my husband, who was a huge supporter of education and training. I know he would be proud of this initiative. Thank you.